Welcome to Clinicals with PHARM VIC. Today I will be talking about hypothyroidism. Rationale for drug use for hypothyroidism include to relieve symptoms, to restore and maintain euthyroid state, and to maintain normal growth and intellectual development in hypothyroid children. Before starting treatment, determine the common causes of primary hypothyroidism, including Hashimoto's thyroiditis, radioactive iodine treatment, and thyroid surgery. Teaching. Also, confirm diagnosis with thyroid function tests, elevated thyroid-stimulating hormone, TSH, with low free thyroxine, T4. In cases of mild abnormalities, confirm persistence of hypothyroidism over 2 to 3 months before starting treatment. Consider possibility of secondary hypothyroidism, TSH typically normal or low with low free T4 due to pituitary or hypothalamic disease. If present, assess need for glucocorticoid replacement before starting thyroid hormone replacement. Adrenal crisis may be precipitated if thyroid hormone is used without glucocorticoid replacement. Consider specific drug precipitants, for example lithium amiodarone. Drug choice for hypothyroidism. Thyroid hormones. Levothyroxine, T4, is the drug of choice for replacement therapy in primary and secondary hypothyroidism. Its long half-life gives stable serum concentrations and a long duration of effect. Liothyronine, T3, has a more rapid onset of action and a shorter duration of effect than levothyroxine. May be used for severe hypothyroidism. For example, myxoedema coma. It is not recommended in pregnancy because of preferential use of T4 by the developing brain. Special cases. In the elderly, start levothyroxine replacement cautiously. Maintenance replacement dose in the elderly may be less than in younger people. In ischemic heart disease, start levothyroxine replacement cautiously. Full replacement dose may not be appropriate. In pregnancy, monitor thyroid function each trimester. Increased levothyroxine dosage is likely to be required during pregnancy, starting in the first trimester. Reassess levothyroxine maintenance dosage 6 to 8 weeks postpartum. In congenital hypothyroidism, replacement therapy should begin as early as possible under careful supervision to prevent intellectual disability. Monitor intellectual and physical development and thyroid function. Or treatment endpoints. Monitor clinical symptoms and thyroid function test results. In primary hypothyroidism, monitor TSH and T4 levels every 6 to 8 weeks and adjust levothyroxine dosage to achieve required TSH, low-mid normal range. Then monitor annually, more frequently in children. Additional monitoring may be required, for example with significant weight change, use of interacting drugs, pregnancy. In hypothyroidism due to hypothalamic or pituitary disease, TSH cannot be used as an indication of adequate replacement. Or adjust levothyroxine dosage to achieve T4 in mid to upper normal range. Subclinical hypothyroidism. Characterized by mild elevation in TSH, often asymptomatic, with normal T4. Risk of progression to overt hypothyroidism is higher in people with thyroid peroxidase antibodies and rising TSH. Monitor thyroid function every 6-12 months. Decision to begin T4 replacement should be individualized. TSH 10 MIUL is generally accepted as an indication to start replacement therapy. Euthyroid goiter. There is conflicting evidence for efficacy of levothyroxine in reducing size or stopping growth of goiter. The possible benefits of levothyroxine treatment should be weighed against possible harm associated with TSH suppression, for example, decreased bone density. Or there is a risk of inducing hyperthyroidism in patients with autonomous nodules. Avoid levothyroxine if TSH is already suppressed. Practice points. In hypothyroidism, levothyroxine replacement is lifelong, except for some people with hypothyroidism following subacute or postpartum thyroiditis, radioactive iodine treatment, or partial thyroidectomy. After transient treatment interruption, And if clinical symptoms are minor, it is usually unnecessary to reintroduce levothyroxine slowly at low doses, including in ischemic heart disease or the elderly. Allow at least 6 weeks after changing levothyroxine dosage before checking TSH, as levothyroxine has a long half-life. Failure to respond to levothyroxine may be due to lack of compliance, which is the most common reason. Possible impaired absorption by food, binding to other drugs in the gut, for example calcium, iron, or disease of the small intestine. Increased levothyroxine clearance by interacting drugs. Possible loss of tablet potency due to inappropriate storage conditions. Overtreatment of hypothyroidism, as shown by suppressed TSH, may increase risk of bone density loss and fracture, particularly in elderly women. Clearance of many drugs, for example digoxin, hypnotics, anesthetic agents, analgesics, is reduced in hypothyroidism. Lower doses may be sufficient. Consider need to increase dose as person becomes euthyroid. If this lesson helped you, don't forget to hit that subscribe button. Please share this video. You never know who might need the right information to ace their exams or become more clinically sound. Let's grow together, learn, revise, and succeed.